I want to thank Loti Hotel Guam, the Medical City, Guam Regional Medical City, Island Cancer Center, FHP Cancer Center, and of course, United Airlines. Ladies and gentlemen, on stage right now from the FHP Cancer Center, radiologist, Dr. Danny Hall.
Thank you. Because of all the people you've had, I'm one of those guys that's in the trenches, and every day I'm trying to find cancer. The reason I did my talk today on what I did is a few years ago, a female doctor went in and had her mammogram. And she got to read a letter in the mail like a lot of women do, and it said it's negative. Congratulations, we'd like to see you again next year. 2 months later, she found a lump in her breast. You know the rest of the story, most of you. She goes in, and sure enough, they do a biopsy, and she's got stage 3 breast cancer. And this was a very intelligent lady, and she wasn't angry, but she was just confused. Because she said, you know, for 13 years I had mammograms, and they told me it was negative. I thought we were doing this to find early stage breast cancer. If I did everything I was supposed to do, why did I have stage 3 breast cancer? And her doctor says, well, we're very sorry, but it turns out you've got dense breasts. She says, what in the world are you talking about? Says, well, you know, a lady that has dense breasts has a lot of white areas on her mammogram, and the cancer can hide in there. And it can get fairly large, and we may never see it until it's too late. And she says, well, you know, I would have liked to have known that. And she's doing well with her treatments, but she did start a campaign that women ought to be informed if they have dense breasts or not. And they ought to be informed about other choices they might have. And I'm glad she did it, for one, because I've been looking at mammograms for 20 years. And she was the brave one that was willing to speak up. So radiologists have been working on this for years. Mammography specialized radiologists have known for years that if a lady has dense breasts, you have to do things to try to look into it a little bit more. So one of the things we can do with that, you can do spot compression views. You can do ultrasounds. You can do MRI. You say, well, why can't you see the tumor? Well, here's why. Someone once described it as looking for a tumor in a dense breast is like looking for a marshmallow in a cloud. It's not going to stand out very well, is it? Unless it pokes itself around the corner or you see something change from one year to the next. Go ahead and move on to the next one. These are all the studies that show that mammography reduces the chances of you dying from breast cancer. Go on to the next one. Sorry, go on. There you go. Now here's a slide that shows why it's important to find cancer at its earliest possible stage. Over there you have numbers at the bottom, 0 through 4, and then the percentage of survival.
Excuse me, sir.
These numbers are probably a little bit optimistic, and they're probably ivory tower kind of numbers. Let's go to the next one. So what do people do in community practices? Well, here's an ideal community practice by people that only do mammography. And in their hands, they find cancers at a little bit earlier stage than the rest of the nation. You can see the numbers over there on one side. The community program is the one that says MP Breast Program, and the one on the other side is national data in the United States. So you can see that if you're dedicated to something, you can do a little bit better job. Let's move on. Here's a chart. You may have already seen this earlier today, but I think it's one that everybody needs to see. One of the problems we have is all breast cancers are not the same. There are different tissue types, there are different presentations, and they look different in different women. In fact, no two breast cancers are exactly alike. Some are more malignant than others. The longer they're in your body, the more malignant they become. So it makes for a real problem when you're just looking at pictures trying to decide what a pathologist is going to say. But you can see on that curve, and you'll see some of the controversies about when we should be spending our money, you can see that even at age 25, there are some women who get breast cancer. And all the way up to about 70 to 75 years of age, it peaks. And about 5 women out of every 1,000 will get breast cancer. In the 40s, that's where most of the controversy comes in. A lot of people want to go every 2 years. Personally, I think we ought to go every year. Again, I'm a cynic. How much of a head start would you like to let your cancer have? Because we are not perfect. The test isn't perfect. It only works about 7 out of 8 times in the best of hands. What if you're that 1 in 8? Are you really interested in giving cancer a 2-year head start? Let's go to the next one and move on to the next. Well, here's a little bit of what I do. I saw this slide the first time at a speech by Dr. Tabar. Many of you don't know who he is, many of you do. Dr. Tabar basically gave us the current version of mammography that we do. He pioneered it. He's famous for reading over 1 million mammograms. If you're going to learn a new enterprise and you want to learn how to be good at it, I think you ought to go to the best people. I think he qualifies. He said that reading mammograms for him is a lot like this painting by Beverly Doolittle. The hills have eyes. At first, when you look at that picture, you see a cowboy and his 2 horses. And then after you've had time to look at it a little bit more, you realize he's surrounded. That's a lot of what looking at a mammogram is like. Hidden in the background of that film are cancers. And lots of other things that aren't cancer, but you have to look at all of them and then dismiss them or look into them more. Go to the next slide. So what I'm trying to say is it's a little bit of a Rorschach test. And we train for many years and we study very hard. But at the end of the day, you do the best you can to recognize something that's going to stand out differently. Dr. Tabar said he doesn't read mammograms looking for cancer. He looks at all the normal things. And then while he's looking at the normal things and admiring God's creation, he spots things that shouldn't be there. I think that's a good way to approach it. Go to the next one. The big problem we have is we scare a lot of women to death every year. In Guam, we scare more than I've seen anywhere. The ideal number would be about 1 out of every 10 women that come in for a mammogram should be recalled back for more views. An acceptable number, the more educated the mammographer is probably close to 15%. So what does that mean? We're thinking we're going to find 6 cancers maybe out of every 1,000 women. That means we're going to call back between 100 and 150 women to find 6 cancers. That's a lot of people to scare to death. So that's why we try to learn better and faster and more efficient ways to find cancer and to worry less people. Go to the next. The second thing on the list they talk about is reasons why you get a false negative report. Congratulations, you don't have breast cancer. Sorry, but we were wrong. You were that 1 in 8. Why did that happen? Well, cancer is very clever. It hides. It hides in the breast tissue in plain sight. Sometimes you have dense breast tissue, and that's one that we can do something about. Poor technique we can do something about by staying on the quality issues. Oversight, you make sure you got people paying attention to what's going on and you audit it. And then readers are variable. Some are better than others. Just like you guys, some of you are better at finding Waldo in the puzzle than others. Some radiologists are like that. Let's go to the next slide. This is a fairly busy slide, and it goes into a lot of anatomy that most of you probably don't care about. Let's go to the next slide. Well, one of the things that radiologists have done to try to deal with this issue of not reporting to women is we went back to some old stuff that we learned 40 years ago. There's a Dr. Wolf that had described about 5 or 6 different patterns in the breast, and we settled on these 4. Type 1 is 0 to 24% fat. Type 2, 25 to 50. Type 3, 50 to, you see how it goes. Okay, how good are we at finding cancer with those different ones? Type 1, my best guess is about 95% of breast cancers can be seen in a fatty breast. In fact, radiologists joke about the mammographer's dream is a fatty breast and lots of old films. Well, why do they want the old films? I'll tell you why. Your mammogram is almost like a fingerprint. It's unique to you. Now, yours might vary from year to year when you take hormones, and sometimes as you age, areas of density that were there last year start to go away. So that's the good news. So each time we're not solving the same puzzle, we're getting another view at it, and we can see if something's changed. If you see a change in contour, a change in density, or something that wasn't there before, that helps us. Let's go to the next slide. Here's an example to you of those different types of mammograms. It's a fairly standard slide. The first one up there is the fatty breast, and that one has probably more density than the one I would have liked to show you. Type 2 is the average, up to 25% to 50%. Type 3 there is 50 to 75. Type 4 is very dense. One of my surgeon friends once called the type 4 hide-a-truck breasts. I know that sounds fairly crude, but he said, my God, Dan, you could hide a truck in there, and I wouldn't know it was there. And that's the truth. Sometimes you won't know it's there with just that film. Go to the next. There's a little bit on the anatomy again. I'll summarize it by saying that most of the badness that goes on in breasts happens in the little structure called the terminal duct lobular unit. Okay, for those of you who want to know that, go to the next slide. If the blueprint looks the same, it's because it was done by the same architect. Those leaves are the terminal duct lobular units. That's where the cancer happens, and then just proximal to those leaves. The base of the tree is down where the nipple is and where all the milk ducts converge. Let's go to the next slide. Every day I'm reminded of the different patterns of breasts that I might see the next day when I'm reading mammograms. Here's another example of the same thing. You have the sky, which is one I like to use. That blue area is a fatty breast. You can find the type 2 and the type 3 and the type 4 all in that same picture. Let's go to the next slide. Here's another one showing those clouds. You can see that over Guam just about any day. The fatty breast up in the upper corner, as you move across, the breast gets progressively more dense. If an airplane were flying through those clouds, you've seen the airplane show up and disappear. Well, that's kind of what we're looking for in a mammogram. We're looking for those airplanes that stand out or something that's new from one year to the next. Go to the next slide. I'm supposed to put that in there to tell you when to start doing mammograms. I've told you how I feel about it, I think, every year, because personally, I don't want to give cancer a head start. Let's go to the next one. This is why we do it. We talk about the expense. Most insurances cover that nowadays. You might be out of pocket a few dollars. Let's go to the next. So, what are the techniques we can do to deal with dense breasts? One of the things that came out is digital mammography. We have digital filming on our cameras now. Our little cell phones have them. They're very accurate. They're very helpful. They improve the contrast. We're able to see through dense breasts better than the old mammograms. And it works better with computer detection, which, in case your radiologist falls asleep during the study, it may put a little dot over there on the density that's new. Frankly, I like having it there, but I'd say it's wrong about 999 times out of 1,000 on the things it highlights. But you know, if you're that 1 in 1,000, that's a key number. Let's go. The second thing we can do is something we don't have in Guam. In 2011, they approved the FDA tomosynthesis. And tomosynthesis, some people call it the 3D mammogram. And what it allows you to do, they take about 30 slices of the breasts, and then you can see around the densities, and you can see contour changes and spot calcifications that you otherwise wouldn't be able to see. All those things cost money, and so I need your help to encourage all the folks who spend that money on Guam to invest in that type of equipment. I think it's going to be a helpful thing to have. Let's go to the next slide. This talks a little bit about the digital mammogram, but let's just move on through that. Most of you have heard of it before now. Ultrasound. Most of you are familiar with it. Some of you might not be. You're like, okay, I had my mammogram. Now they want me to come back for an ultrasound. Why is that? Well, the ultrasound doesn't care how dense your breasts are, and it allows us to see things that we wouldn't otherwise see. Many of the experts now are recommending in all of our reports that if you're one of those ladies that has dense breasts, that they might want to consider doing an ultrasound this year and next year also. Let's go to the next slide. Someone did a study on that in 2,000 high-risk women. They found 40 cancers. 8 of those cancers were seen both on the mammogram and the ultrasound. 12 were just seen on the mammogram, 12 by the ultrasound, and only on the ultrasound, and then 8 were missed by both. So I'd say, what is that, about a 20% failure rate? That's the real truth. Some of you may be hearing this for the first time. So what do you do about those other 8? Well, I would say that we need to be thinking about how we can improve using MRI to help find some of those cancers. A very controversial study came out this summer, most of you probably didn't hear about. Someone took less than 500 women who had been to their mammography center, and they were all told they didn't have cancer. They had a mammogram and they had an ultrasound, but they were higher than normal risk. They did what's called a fast scan MRI. It took 11 minutes. Guess how many cancers they found? 17 out of a little over 400 and some women who were told they didn't have cancer. And I think 7 of those were invasive cancer. So that's why this is of great interest to most of us. Let's go to the next slide. This shows the reported sensitivity in 2004. And it's not in the Radiology Journal, it's in the New England Journal of Medicine, a very highly respected journal. It showed a sensitivity rate in high-risk women of 71% for MRI and a specificity of almost 90%. Look at mammography on that same comparison and look at the clinical exam, 40 and less than 20. Let's go to the next slide. Here's an example for you. An actual patient. On one side, we have her mammogram that shows she has dense breasts. You can play my job and look around for the cancer in there. On the other side, you have MRI of the breast with CAD stream and analysis. All that red stuff in there on the left side is cancer. Let's go to the next slide. These are the criteria for which women are at high risk and ought to have breast MRI. I won't bother you with all those details. Let's go to the next slide. This is a little talk on tomosynthesis. If you could just move through those fairly quickly. Go ahead and go to the next one. Basically, they swing the tube in a 30-degree arc, and it produces a near three-dimensional image. Go to the next one. This is kind of an illustration of how that all works. There's your breast down there getting compressed between the plates. There's the image at the end where it says detector, and there's the positions of the tube. Go to the next slide. Here's what it looks like. It will fit in just about any mammo suite that you know of. Let's go to the next slide. So they compared this. How much difference does it make? Well, the numbers are not terribly impressive until you start looking at a lot of different women, but you can see that in dense breasts, the sensitivity went from 2 out of 3 up to 3 out of 4, which is a considerable number. The specificity improved a marginal amount better, but the recall rate was reduced by 43%. So instead of calling back 15 women, you might be calling back, let's say, 7. That's a considerable improvement. Let's go to the next slide. Here's a patient that presented at FHP. No family history of breast cancer. In fact, I hear this talk all the time. If you're having a mammogram and you come to my place, you've got cancer until I prove you don't. Now, I care about whether you have a family history, but it ain't going to make me any less suspicious. Let's go to the next slide. Here's her mammogram. A dense breast, heterogeneous densities on the right side. Now, here's where the story gets a little bit confusing. A year ago, she had a breast ultrasound. She had a very competent doctor from the Cleveland Clinic do a biopsy. It was sent to a very competent pathologist in Hawaii, and it came back as a benign lesion. Whew. We made it, right? Only one problem. It came back as a fibroadenoma. So she comes back the next year, and it looked a little bit different. One of our radiologists picked up on that fact. Let's go to the next slide. Then the next one. Here's a spot compression view. I told you how that helps. Now we've pushed the clouds out of the way, if you will, and we're seeing that lesion that was biopsied and we were told was benign last year. Let's go to the next slide. Now, we did the ultrasound before we went to MRI, but you ask yourself, well, we've already biopsied that lesion. It wasn't cancer. We've been watching it. Nothing's really happening, except it looks a little bit different. Well, this was done on our 3 Tesla MRI, the only private one on Guam. This is the Hubble telescope of MRIs compared to the standard 1.5. You can see things that are smaller, you can see them better, you can see them faster. There's the cancer on the right, and to me, it stands out like a goldfish in a bowl. I like that because, as clever as I think I am, I need all the help I can get some days. I like to be able to see things very clearly. The part that you're seeing that's sort of a light gray is the dense breast tissue. If you go back to those mammograms that I was telling you about, MRI doesn't care how dense your breast is. It's looking at something totally different. It's looking at, does the cancer have a blood supply? Does it eat up a lot of contrast? Because guess what? Like Dr. Chaudhry is telling you, cancers are hungry. They've got to be fed. And we take advantage of that. We find those blood vessels and we see the enhancement. Let's go to the next slide. Here it is looking from the side, and there's one of those blood vessels that's associated with that same tumor. Go to the next slide. There's that lesion, same tumor under ultrasound. Has about the same configuration. Go to the next slide. There's where we went in and biopsied it again. And to go to the next one. And so, sometimes my message to you is, don't always take the first answer. Somebody here talked about a lady like that. She'd been to 3 or 4 different places. She went to Mecca after Mecca after Mecca. But she stuck with it until she got the right answer. And when it comes to detecting breast cancer, that's what we all have to do. Let's go to the next slide. One of the things I like to be able to do when we do a breast MRI and it doesn't show anything suspicious is to take a lady who's been scared to death for the last 5 years by callback after callback and ultrasound after ultrasound and say, you know what, go out and enjoy your life for another year. The odds are about 99% that you don't have invasive breast cancer and you don't need to be concerned about this for a while. Now, we don't always do that completely because, again, I told you I'm a cynic. I may bring her back in 6 months and just take another look around because I know that bad things happen and we are just doctors. We're not God. We are not perfect. And you just got to be persistent in this world to achieve things.
All right, ladies and gentlemen, please, one more time, give it up for Dr. Hall.